Okay. So I know Shaper got to look over stuff. He came in with questions. Anybody else got any questions for me? Huh?
Just about that picture.
That face trauma picture?
Yeah.
Yeah, he's still alive and it is possible.
Do you know the story behind that one?
It was, usually it shifts forward and it gets the face and then...
Oh, you shot yourself?
Uh-huh.
Oh.
Yeah, most of the time. We'll see, it doesn't look like it's starting. Okay. So, as you can guess, today we're going to be talking about thoracic trauma, abdominal trauma, various kinds of trauma. Okay? It never all works together. Okay. All right. Chest trauma is the second leading cause of trauma trauma deaths, secondary to head injuries. Okay. Do you guys remember we kind of mentioned what the problem is with a head injury? Do you guys remember what it is that becomes extremely problematic initially with a head injury as far as EMS is concerned? Airway. Okay. Well, what do you think the chest trauma is going to impact or affect? Breathing. The breathing part of it, right? Okay. And this accounts for about 20% of all trauma deaths. Okay. Let's see if this will work. Okay. So maybe at least my pointer will work. And some of these pictures, you know, as I was looking through them, I was like, some of these are pretty hard to see. Does that help at all? Okay. So remember we talked that the right lobe, or right lung has 3 lobes. So here's the superior lobe, kind of here. Middle lobe, inferior lobe. And then there's that ligament that runs straight down the center. Okay. And then the liver. And the liver, predominantly when we talk about the liver, we generally think of it as being on the right side. And the way I kind of remember that is it's the opposite, right? Because I would think liver left. So I remember liver right because it's the opposite. But a good part of the liver does extend over to that left upper quadrant. Okay, and we'll talk a little bit about that. The diaphragm would be here. And then, of course, the inferior lobe and the superior lobe. And then there's this boundary kind of between the 2 lungs. Okay? Now this one is much harder to see. All right, how many of you guys were able to look over this and kind of see what you were looking at?
I was lost.
You were lost? Okay. So basically, yeah, this right here is your heart. And this is talking about all the vessels, okay, or the vascular. Here's the superior vena cava. Okay? And then you got your pulmonary arteries. And you remember what your pulmonary arteries do? What? Right. They come off of where?
The heart. Or the lungs.
The what? The right ventricle. And it shuttles the blood to the lungs where it's going to pick up oxygen, become oxygenated. Then it's going to come back through the... Do what? Pulmonary veins. And see, and part of the reason that this is a difficult picture to see is because a lot of this happens on the back side of the heart where we can't see it. Okay, so a lot of that vascular kind of comes in on the back side of the heart. Why do you think that is? Any guesses on maybe why we were created that way? Yeah, because it's kind of right there between the spine and that kind of stuff, hoping to protect some of the main vessels. Okay, so now you can kind of see how it sits. Here's the superior left lung or left lobe. Here's the inferior left lobe. Okay, so you can kind of see how it sits in between. Okay, and that's even for probably some more protection, which is also, we got rib cage also. Okay, the right atrium is kind of hard to see. Then you're going to have your ventricle here, left ventricle, and then the left atrium is going to be back in there. Okay? So, your initial exam is directed towards things like open pneumothorax, and we're going to talk about each one of these individually, okay, guys? So, open pneumothorax, flail chest, which we've kind of already talked about a little bit, right? Tension pneumothorax, massive hemothorax. Do you guys remember the difference between hemothorax and pneumothorax?
Air.
Blood and air. Okay, and then cardiac tamponade. We mentioned cardiac tamponade. Okay, so be thinking about that one too. So what we're looking for here in our initial assessment is these immediate life threats. Remember the 3 times that people are going to die from a trauma? The 3 timelines?
1 to 3 hours, or 4 to 6 weeks, or there's one in between it.
2 to 4 weeks. No.
What's 4 to 6 weeks?
So 4 to 6 weeks, and that's our sepsis and end organ failure. And then there's that several hour window, and then there's, what's the other one? There's the 1 to 3 hour window, which is what we're really concerned with, right? Because the other one is less than an hour, right? Remember, those things that kill us in less than an hour are the things that we can't do much about, right? Those high-speed C-spine lesions, significant head injuries, aortic shears. Okay, you guys remember some of those things that we talked about the other day? Shay, are you with me today? All right. So rib fractures. Rib fractures are the most common cause, or common injury. Why do you think it's more common in adults than in children? Yeah, they're very pliable, okay? And we know this from, we talked about this when we were talking about CPR, right? The difference between doing CPR on a child is much different than doing CPR, say, on even an elderly person, okay? And then, of course, as we age, we get more calcified, okay? We get more rigid, more stiff, okay? So they give even less, all right? Ribs form rings, obviously, so consider a possibility of a break in 2 places. Now, we talked a little bit about the pelvis and how that works, like, remember the pretzel thing? So the ribs are kind of the same way, only it's likely to happen, but not quite as likely as it is with the pelvis. Do you guys remember what I'm talking about? It's harder to break in one spot without breaking it in a second spot because it forms that ring, okay? Most commonly, it's the 5th to 9 rib, and that's poor protection, okay? Fractures of the 1st and 2nd require a lot of force, okay? 1st and 2nd ribs are way up here, plus location, 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 right? So we got to think about that. In addition to, if they have 1st or 2nd rib fractures, what are some of the other underlying structures that are right around there, guys, that we probably should be concerned with?
Lungs or heart?
Lungs and heart, of course. How about major vessels? Yeah. So we may have some major vascular involvement, right? Which would put them probably in that less than an hour time frame of that window. So they frequently have injuries to the aorta or the bronchi, which is even higher up, right? Remember, we have the main bronchus, and then it splits into the left and right main stem. Okay? So those structures are all kind of right here, which is right where my 1st and 2nd ribs are at. Okay? About 30% of them will die, and that's just because of the, not because of the rib fracture, but because of the other structures that typically get damaged when we start talking about a traumatic force like that. Okay, is everybody with me? Are y'all sleepy this morning? Yeah? At least somebody is. Yeah. All right. Fractures of the 8th to 12th rib can damage some underlying abdominal solid organs. Liver, spleen, kidneys. Okay? Do you guys, how many of you guys looked ahead and know the difference between a solid organ and a hollow organ? Yeah? Good. We're going to talk a little bit more about it, so you probably have a little bit more understanding when you come. Excellent. All right, so signs and symptoms. How many of you guys have ever had a broken rib? Yeah, I've been pretty fortunate. I haven't had, knock on wood, any broken bones for myself. So, localized pain and tenderness. They have a lot of pain. They tend to do a lot of self-splinting, right? Because it hurts when I move, like any other fracture, okay? Water runs under the bridge. So remember when we talked about the way our ribs are shaped, underneath the inside edge of each one of our ribs, we have an artery, a nerve, and a vein bundle that run right under there, right? So it's a very, you're going to feel it when you break a rib. Not only that, think about the underlying structures that you get pain with every time that inhalation and exhalation work, okay? Pain is going to increase, of course, when they cough, move, or breathe deeply. And these guys don't like to breathe deeply. They're going to, okay? Chest wall instability. Now, when do you think you'll get chest wall instability, guys? Let's think about this for a minute. Huh? Right, so when you have multiple rib fractures, usually in more places than one, because it's a pretty firm structure, right? And you're probably not going to push hard enough to find out that rib is unstable, because if you do that, you may be causing further damage, right? Okay. Deformity. Discoloration. What kind of discoloration are they talking about? Bruising. How long does it take, you think, to get bruising? What will happen before I bruise? How about that? Redness. Redness from the initial impact sometimes, right? So from my seat belts, from where I got kicked by the horse, kind of thing, you should expect to see some of those discolorations even before, okay? And then associated pneumo or hemothorax. That's going to depend on kind of the severity, the force, the injury, okay? So what am I going to do to take care of these guys? High flow O2, splint using a pillow, swaths, right? Because the swath is going to help hold their arm. Because even moving this, how many of you guys have ever done laid off of the gym for a while and then you do a pretty good ab workout and you don't realize how much you use your abs or even your intercostal muscles until you're hurting or sore. You can't hardly roll out of bed, right? Or even move your arms to reach stuff. And that's what they're talking about here, is by helping swath that arm, you're going to help decrease the movement. Okay? Encourage patients to breathe deeply. Now that is a chore all in itself, right? Because it hurts when you breathe deeply. Okay? But otherwise they're not oxygenating and ventilating well. And that's problematic. Right? Okay. Monitor elderly patients and COPD patients carefully. So this is when we really need to make sure we get a good history on our trauma patients, right? We've kind of talked a lot about that and how it's going to affect them. Broken ribs can cause decompensation, okay? Remember, what are some of the changes that our elderly folks face that will be contributing factors, aside from COPD, because that one's a given right up here. Aside from COPD, what are some contributing factors that will make them deteriorate or decompensate based on those rib fractures? Any guesses, Kaylee? What are some of the contributing factors that elderly people will face that will contribute to that decompensation for rib fractures? What happens to their musculature, right? What happens to their ability, right? I see you nod. So how does that affect it, John?
It's more exposed, I guess. The bones are more exposed.
They don't have the ability to compensate, right? Because they don't have, like, for example, if you damage a rib, you can depend more on your diaphragm and your intercostal muscles, right, to assist you with breathing, right? Well, what happens when you become elderly? Not only do your bones calcify, but what happens with your ability to expand and the muscles in general? They get fatigued, right? They get fatigued early. Are y'all with me? Kind of understand? Okay. They'll fail to breathe deeply and cough, and this usually results in poor ability to clear secretions. Okay? people, elderly people with rib fractures can easily go into ARDS, which is adult respiratory distress syndrome. Okay?
What about COPD?
Same concept. COPD is especially, they can't clear those secretions because those COPD folks have secretions on a regular basis, just about. Okay? And then it leads to things like pneumonia. These guys will be really susceptible to pneumonia. What happens to their immune systems as we age? Right? There's a reason that the extremely young and the extremely old are at high risk for even death due to the flu that you and I could get and kick in a week. Okay? Flail chest is 2 or more ribs broken in 2 or more places. And we kind of talked about this. It produces this free-floating chest wall, right? Now this is when you're really going to have some instability in the chest wall. Paradoxal movement, that kind of stuff, okay? Usually secondary to blunt trauma, okay? And then, obviously, for the obvious reasons that we've already talked about, it's more common for older patients, okay? So, signs and symptoms. There's that paradoxal chest movement that we were talking about. Can you guys see that? When the broken ribs, when we breathe out and expand our chest, the section of ribs that are broken will come in because they are not part of the structure. Okay, so it basically moves opposite. A section of the ribs move opposite than everything else. May not be present initially due to intercostal spasms. You know, when we have fractures, spasms are one of the big things that cause us pain or problems. Okay, and we already talked a little bit actually about femur fractures. That causes a significant amount of pain, is the spasms that your quad goes into. That's one of the reasons when we put it under tension and we pull it, that we reduce those muscle spasms and also reduce further damage and pain. Okay, be suspicious of any patient with chest wall tenderness or crepitus. Okay, you guys know what crepitus is? No guesses? You can feel crepitus. So remember I told you you have got to put hands on folks. Tenderness is what? Pain, right? It hurts. And then crepitus is you'll feel it. It's kind of hard to explain. It's not really Rice Krispies. It just feels like it moves. You can feel almost, I don't want to call it a grinding, but something similar to that, okay? You feel it.
Like fragments?
Yes. Yeah, so if I would touch you, John, and I would feel crepitus, and you'll see it even with the broken arm here, right? When I'm assessing, you can feel it when those bones don't move right, and it almost feels like a grind, just an instability. And you're going to feel it, and you're going to go, ooh, okay, it doesn't feel right. Consequences, of course, pain leading to decreased ventilation, increased work of breathing, and then contusion of the lung. You guys remember what a lung contusion is?
Bruise.
Yep, bruising of the lung. How are we going to help them? High flow too, essentially. We need to establish an airway, though. What's the concern? What should be a big concern that I have if I have a patient that has a flail chest segment? You're going to have to speak up, John, because I bet you Nelly couldn't hear you in the back.
Like if the ribs punctured any other organ.
What kind of force did it take to break these 2 or more ribs in 2 or more places? And you're absolutely right. If it had enough force to break those ribs, what underlying injuries do I have, right? So as if the pain isn't enough and the complications from that isn't enough, I need to be thinking about kind of what else, what other damage was caused and what other structures are in trouble, okay? So we need to make sure they have an airway, right? Depending on where it's at, it can have a significant effect on my airway. We already kind of talked about those higher up ribs, which is really unlikely, okay? But you can bet if you have a flail chest segment in the higher ribs, then you're going to have some significant underlying damage, okay? Suspect spinal injury, again, the amount of force that it takes to cause a flail chest segment, depending on your patient, okay? Remember, elderly folks can bend over and fracture their spine, literally, okay? So kind of keep that in mind, okay? And then assist ventilations with the BVM and oxygen. How come? How come it doesn't say high flow O2 via non-rebreather?
They can't breathe on their own.
They're not going to breathe deep because it hurts, guys. This really hurts, okay? So we need to make sure that they're getting good oxygenation and ventilation. Okay, and then stabilize the chest wall, and that's very important. We need to treat these like any other fracture, okay? Because if it hasn't caused that hemopneumo, what happens to broken ribs or bones in general? How many of you guys have seen? They get sharp, don't they? They break and they're sharp. So you can cause further damage by not splinting in an appropriate patient when you have time to do so. Right? You guys remember when we were going to splint some of this stuff? Remember from our patient trauma assessment? Later on, right, we're going to establish our ABCs. Now this is a little different because this is part of that breathing part. Okay? So just keep in mind, we don't sometimes splint some of these fractures until later, depending on our patient's overall condition. Okay? Simple pneumothorax is the air in the pleural space. Partial or complete lung collapse can occur. So, okay, you remember we talked about the parietal pleura and the visceral pleura? Do you guys all remember what that is? Okay. So, this is when air kind of gets in between those. See how it's pushing on that lung? Makes it impossible for it to inflate.
This is what you're talking about, the bag effect.
Yep. Yep, absolutely. This is that paper bag, plastic bag effect. Okay? Are you good, Shaver?
Yeah.
Okay. So, causes. Chest wall penetration, of course. Fractured rib lacerating a lung. Okay? That you're probably going to see more, well, maybe. All right. Blunt trauma. That's that paper bag effect. You hit it, you pop that bag, right? It's just like when you used to blow up the bag and you pop it. Same concept, okay? And then may occur spontaneously following exertion, coughing, or air travel. Okay? Once these people have a spontaneous pneumo, they're more susceptible to it. Tall, thin, black men are at higher risk for spontaneous pneumothorax. I worked in the ER and I had a guy walk up to the trauma or to the triage area and go, "Hey, I got another pneumothorax. I was on my run. I could tell I was short of breath. I got my bag packed." Sure enough, did an x-ray and he had a simple pneumo. So he was no stranger to it. Some signs and symptoms. Pain on inhalation. Are we seeing a pattern here? Okay. So sometimes it may be kind of hard to differentiate. Other than, what are we going to use to differentiate some of these?
X-ray.
Well, we don't have x-ray. How about presentation? Right?
If they're not.
Their MOI and their presentation should lead us significantly to kind of that index of suspicion. Remember, we talked a lot about index of suspicion based on our mechanism of injury the other day. Well, if somebody comes in and they don't really have much of a mechanism, but they're exhibiting some of these symptoms, we need to probably be thinking maybe they've got a spontaneous pneumothorax. Okay? Depending on how big it is, they will have difficulty breathing. And then, do you guys remember what tachypnea is?
Slow breathing.
Fast breathing.
Fast.
Fast breathing. And that's because they're not going to breathe as deep, right? Plus, they're not making as much gas exchange, so they're going to have to increase. Remember, our tidal volume is how much we breathe a minute overall. So if I can't get as much air each time, if I can't do as much gas exchange each time I take a breath, I'm going to have to breathe more often so that I can keep that up, right? Okay? And then decreased or absent breath sounds. Now that's going to depend on kind of how big it is. Because you can have a pneumothorax that's really small, that they might not even do a chest tube for. They just might watch it. Okay? So that's going to determine how big the pneumothorax is.
Is there any kind of hole in the simple pneumothorax? I always think of like...
Not externally.
Okay, but so how does the air get in there?
Well, think about the paper bag effect.
I know.
So it causes damage to the lung, but not necessarily...
What's the paper bag, your lung, is that...
You blow up a bag,
Okay.
and if you blunt trauma and you hit it, what happens to the air in the bag?
It okay, yeah, it pops and then there's a
There you
hole
go.
in the lung.
Yep.
What if there is no
But
blood
it's-
trauma? You just...
Yeah, I don't know the
Lung in the lung, or-
yeah, and I don't know why. I don't know if anybody. I'm sure some physician somewhere knows why. but I don't know, the spontaneous pneumo you mean?
Yeah.
Yeah, those are kind of a freak thing, so to speak. Okay, although remember it does happen often from like coughing, those kind of things, which essentially can cause the same type of an effect. Okay.
Does that heal? Does that little space heal?
Yes, eventually.
On its own?
Well, it depends on the size and location of it. Sometimes they have to put a chest tube in to get rid of that air so that it can kind of come back up, and then it's a slow healing process. Okay. Kind of talked about that. Let's see. So management, we're going to, of course, again, make sure they have an airway. Suspect spinal trauma based on mechanism. High concentration O2 with a non-rebreather. Why do you think we don't want to use a BVM on these folks?
Because they're certain pop, but
Make the hole bigger.
It's already popped. I may not make that hole bigger, but what am I going to put in that space? Yeah, I'm going to force a lot more air into it. And then I can actually create or potentiate a tension pneumothorax, which we're going to talk about here in a second. Okay? So by all means, if they need it, we don't withhold BVM, but we need to be aware of kind of the process and how it works and what may happen as a result of that. Okay? What we need to watch for. Okay? So high concentration O2 with a non-rebreather. Assist decreased or rapid respirations with the BVM. So again, don't withhold it. Just keep in mind you need to know what to look for in some of the changes that you may be that may come a little quicker with your patients if you're having a BVM them. Okay? And then monitor for progression of a tension pneumothorax. All right? Any questions on that? Excellent. Open pneumothorax is basically a hole in the chest wall. So this is going to be more from your penetrating trauma. Okay? It allows air to enter into this pleural space. Okay? So it goes into that same spot. However, the larger hole, the greater the chances will enter there rather than through the trachea. So the problem is, it takes the path of least resistance, right? So if you've got a hole on your chest that's bigger than the hole that's allowing air to come in here, where do you think the air is going to go? Path of least resistance. You're going to get more air through the hole in your chest than through your trachea. So again, how does that affect your current condition? One, you're not able to oxygenate or ventilate, right? Because it's going to all the wrong spots. The air isn't going to get into the alveoli sac of the alveoli that are still functioning, so that it can make that gas exchange across the membrane. Y'all with me?
So it's just like in, one out without even oxygenating.
Right, right. Because it kind of builds up in that space that doesn't do gas exchange. That space that air is not supposed to be in. Okay? Jonathan, are you with me? Excellent. Okay, and this creates what they call a sucking chest wound, right? For that very reason. So management, close the hole with occlusive dressing. Now, you can use a 3-sided or they say even a 4-sided occlusive dressing. You just have to watch that you may have to burp it. So what happens if I put an occlusive dressing on your chest wall and I take 3 sides? When I suck in, what happens to my dressing? It sucks down and closes that hole. But when I breathe out, it flutters, and so it allows air, ideally, it'll allow air to escape but not allow air in. Okay? So that's kind of the concept. If you put a 4-sided occlusive dressing on, you may have to burp it. And we'll talk about that in just a second. Okay? High concentration of O2. Assist ventilations because they are going to need it, right? If they have a significant enough injury, not only to their chest wall, but to the underlying structures, they're going to need some help oxygenating, ventilating. Okay? Consider transport on the injured side. Paige, why do you think we're going to transport on the injured side? Now, this is going to depend on how able, their mechanism, what other injuries we're suspecting, Any ideas? If you don't, that's okay.
because it's heavy.
It is heavy.
Keep pressure on it.
Okay, so it does a few things. So right, it's going to keep pressure on it. So it's going to help stabilize any unstable structures. Sure. It is heavy, so what does it do? It's going to fatigue. If I put them on the wrong side, it's going to fatigue. And not only that, where is everything going to drain?
To the good side.
to the good side. Now I may end up compromising my good side due to the drain of blood, fluids, etc., right? So there's several reasons we may want to consider that. Now, does that mean that I have to turn them completely on that side? Maybe I just stick something underneath the edge of the backboard just enough to tilt it just a little bit to let gravity work for me. Okay? So we can still tilt the backboards, right? Okay. And then, again, monitor for progression of a tension pneumothorax. How many of you guys are kind of going, all right, what is a tension pneumothorax already? Yeah? A couple of you? They didn't read ahead, did they, John? Okay, tension pneumothorax. This is when a one-way valve forms inside the chest wall, okay? So air enters the pleural space, but it can't get out. It can't go anywhere. So what's going to happen? It continues to come in, but it can't get out. Next time we take a breath or we ventilate, it continues to go in, but it can't go out. It is going to put some pressure on everything in that cavity, in that thoracic area, okay? So air gets trapped in that pleural space, and then the pressure rises, and then it causes this lung. See how small that lung is? This is all air, and it's just pushing and pushing and pushing. It's like I'm here, I have nowhere to go, so it's going to continue to compromise the lung. Okay? So not only does it compromise your lung, but after it fills up, everything in that lung is completely collapsed. What else is it going to push on? The heart, the inferior vena cava, the aorta. What else is in there? Just about everything, right? It can eventually start putting pressure on the other lung. Now we've got big problems, right?
How
Okay.
long does that take?
It's going to depend on the size. It's going to depend on the size of the initial blow. Yep. Size of the initial blow and how, you know. Now, on the same note, if you have two of the exact same patients, he's bagging one and John's bagging one, right? And John's over here just going to town, bagging too much or too fast, which we've talked a lot about, right? Why it's really important we have to have controlled bagging. Now who's going to progress quicker? Right. The patient who's getting overbagged. Okay? So the same concept. It's going to depend on kind of several things. Okay? The vena cava becomes kinked. Okay? Blood cannot return to the heart. And stroke volume falls and it decreases your cardiac output. What happens when my cardiac output decreases? When my heart can't punch the blood out. Shock. Right? Blood pressure falls. We can't end oxygenation, right? You remember the definition for shock?
That you can like rest five parts, right, or something like that.
Something kind of like that. Okay.
What is it? Bad perfusion, because the guy told us.
Oxygenation and perfusion, because remember it's not the same thing, but perfusion means that I'm getting oxygen to the oxygen nutrients to the place that needs it. Okay. Signs and symptoms: hypotension, all right, tachycardia, tachypnea. We remember what that all is, right? Low blood pressure, high heart rate, high breathing rate. Well, that sounds an awful lot like shock, doesn't it? Remember that? Okay? They get extreme dyspnea, so they are really having a hard time breathing. Why do they get restless, have anxiety and agitation? So they're not oxygenating their brain, right? Remember what's the best indication of the oxygenation to the brain? Mental status. There you go. Good job. They're going to have decreased breath sounds. Okay? Hyperresonance to percussion. Do you guys know what that means? That means whenever you, and you kind of percuss, you put your hand here, you kind of tap. How many of you guys have ever bought a watermelon or a cantaloupe? And it sounds kind of hollow if you thump your watermelon. Same concept. Okay? It's gonna be kind of that loud, hollow sound, right? Because that's air. Okay? And it is pretty hard to do that in the field because we work in these environments that are kind of hard to control and they tend to be loud and whatnot. Okay? Cyanosis. You guys remember cyanosis is what color? Huh?
Late stage of hypoxia?
It is a late stage of hypoxia. It's kind of that bluish or purple color, usually nail beds, lips, mouth, nose kind of thing. Okay? And then subcutaneous emphysema. Now, this is when air gets trapped kind of under the skin. And when you feel it, it feels like Rice Krispies under the skin, like bubble wrap. Okay? That indicates a significant injury. All right? Rapid weak pulse, decreased blood pressure. Trachea may shift away from the injured side. This is going to be a late sign. Why does it shift away from the injured side? Yeah, because it's being pushed. Like everything else, it's part of those structures. So you can only push on this stuff so far before you start having to shift up here a little bit. Okay? Now, jugular vein distension. Why would we have that? Right, because it's putting so much pressure, blood can't return to the heart, remember? So the inferior and superior, which would be affected, the superior vena cava, can't empty into the heart. So it's got to go somewhere. Right? Now, why does it say possible? When would I maybe not see this? Any guesses?
What do you mean, like?
William, if I have something like, if I have an injury significant enough to cause some of this on me, what other injuries would you be considering?
Internal bleeding.
Haha. So maybe my blood's all bled out somewhere else. Okay? So may or may not see that. Okay? So it's just a thought. It's going to depend on some of the other problems, right, Devin? Okay. So what am I going to do to manage these guys? Sorry, Javier. Secure the airway. High concentration of O2 with a non-rebreather. If available, you can request for an ALS intercept because they can do this. They can do pleural decompression or needle decompression, which is basically kind of like a makeshift chest tube, essentially until you get to the ER. Now, spinal immobilization if necessary. Rapid transport to the closest hospital. Now, we talked quite a bit about closest versus most appropriate, right? This is one of those things that will kill you in the next little bit if you don't address it. This is a true life-threatening emergency. So that's why they say if you don't have ALS intercept that can fix this problem, you have to go to the closest hospital because they can. So remember, if they need surgery because they're having intra-abdominal bleed, where do we go? The place that's going to provide them surgery that they need, because that's the life-saving event that they need, right? Well, if it's needle decompression or a chest tube, any ER can do that. Okay? So make sure you know kind of when you get out there what hospitals are local to you and what their capabilities are. Okay? Because most people didn't think that any ER, they had to be a trauma center. They do not have to be a trauma center to be able to put in a chest tube. Okay? Questions on that one before I move on?
So that needle decompression, is it like it leaves the needle in, or is it like a catheter?
Well, we use a catheter. It's usually an over the needle catheter. So we go in and we decompress until you get the whoosh of air, and then you pull the needle out, and then you put a flutter valve on it so that it works kind of like it. Just like that, like a check valve. So when I breathe out, it lets the air escape, but when I breathe in, it's going to close that hole off. So it's just kind of a, yeah, absolutely. And this is still temporary. This is still temporizing, okay? They still need a chest tube and possibly the OR, depending on injuries.
So that's just to drain the air out.
Yeah.
And then you put the pipe over it and that works as a one-way valve.
Yep. Yep. And we put them up here, like second, third intercostal space. Chest tubes go in the fifth or sixth intercostal space down here. So we also kind of try to keep it so that they can still do that chest tube when we get to the
Why
ER.
are those tubes so thick?
The chest tubes?
Yeah.
Because it has to be big enough to allow air to come out. They also put, they have little machines that cause it to bubble. And if they have a really big hemothorax, they can actually catch that patient's blood and then filter it and re-administer their own blood so they don't have some of those issues. So it just kind of depends. And yeah, they don't go to the OR to do that. They do it right in the ER. Sometimes they numb them, and sometimes it's, sorry, we don't have time for this. Okay? Hemothorax. It's basically kind of the same thing we've been talking about, right? Only it's blood in the pleural space. Most common results from major chest wall trauma, of course, right? Because I'm sure you're probably thinking, well, when are they going to have this major trauma and it's just going to be air and not be blood? That's why pneumothorax is about 20%. Hemothorax possibilities are much higher, 70-80% probably. Okay? Oh, okay, there you go. Present in about 70-80% of penetrating major non-penetrating trauma. Okay? Sir?
And an open pneumothorax, how is there not blood getting in there on that?
Well, generally there is. And when they talk about open pneumo versus closed
Like
pneumo,
literally a hole.
yeah.
Is that all it's saying? Instead of just the popping along, there's like an actual opening.
Yes.
Okay.
It's actually an opening plus not only that, but if it's open, you won't have the blood accumulation as much as you will the air, right? Because the blood can drain out.
Wow, okay.
Okay? So it kind of gives you an escape, if you will. And the problem is, while the blood comes out, remember every time the air will just kind of rush in. We can't keep air from rushing in. Remember that was the problem. That's why we had to use that occlusive dressing. Make sense? Okay. Signs and symptoms. This is gonna look a little familiar to you, I would guess. Okay. Rapid weak pulse, cool clammy skin, all signs of shock. Very good. Restlessness and anxiety because hypoxia to the brain, right? We're not perfusing the melon very well. Okay. And then thirst, chills, hypotension, collapsed neck veins. So you're going to have real flat neck veins. They're not going to have that big, fat, engorged. How come? Blood loss. Right? He said, is this a duck question? Yes, kind of. Okay. Decreased breath sounds. Now, when you percuss their chest, it's going to sound dull. It's going to sound like a gallon of milk. If you were to put your hand on a gallon of milk and kind of do this, it will sound dull, not real airy. Okay, not that hollow sound. Okay, dyspnea and then ventilatory failure, of course, for multiple reasons, right? We're not carrying oxygen. We can't oxygenate, don't have hemoglobin, losing blood, shock, and we're not ventilating well because we don't have the ability to expand our lung, right? So this is like a big whammy, okay? Secure the airway, assist breathing with high concentration O2. Why are we going to do that for these guys?
Because they can't oxygenate.
Right, but they also, remember, when we bleed out, we lose our hemoglobin, so we don't have as high of ability to carry oxygen either. Okay, so we need to make sure that all the oxygen, or all the hemoglobin we have is carrying oxygen to try to make that gas exchange, we hope. Spinal immobilization if necessary. And then again, rapid transport. Blunt force to the chest can cause increased interthoracic pressure and a backward flow of blood out of the heart into the vessels and the upper head and cheek. This is traumatic asphyxiation. Okay, have you guys heard of asphyxiation before? Yeah, kind of. Sure is. So, possible sternal fractures or central flail chest. Again, what kind of force does it take, Devin, do you think, to cause traumatic asphyxiation? A lot. It takes a very high force, okay? Purplish or red discoloration of the head, neck, shoulders. Okay? Remember, it pushes blood out of those areas and kind of pushes it up. So that's why we get that purplish red color. Okay? Bloodshot or protruding eyes, literally. Have you guys seen those little balls that you squeeze? And when you squeeze it, like the guys whose eyeballs come out, it's the same concept. It really is. So when you squeeze it all from one spot, it's got to come out somewhere else, right? It's got to go somewhere else.
So this doesn't have to do with the lungs. This has to do with just blunt trauma forcing the blood that's like maybe coming up from the superior
Right.
up like back to where it was.
Yep. Okay, and then swollen cyanotic lips, again, they get blood engorged there. That's where they get the swollen. They aren't able to make gas exchange, right? Because pressure blew blood out of everywhere, so you don't have any blood making gas exchange. Okay? And the name is given to patients because just that, they look like they've been strangled or hanged. Okay? Management. Airway with C-spine control. Remember, this is a significant force that it took to do this, so you have to assume that they have got spinal compromise. Okay? Assist ventilations with high concentration O2, spinal stabilization, rapid transport. Not much we can do for this in the field. Early recognition, supportive care, rapid transport. Okay? Cardiovascular trauma. Any patient with significant blunt or penetrating trauma to the chest, you need to kind of assume that the heart and great vessels have involved, right? Because what happens if we don't assume and they were involved? They die, right? If we kind of think, I think that this may have heart and vessel involvement, and it didn't, are we any worse off? Better yet, is our patient any worse off? Absolutely not. Okay? Myocardial contusion is a bruise of the heart muscle, most commonly in blunt cardiac injury. So this could be your 14-year-old Little League pitcher who takes a baseball smooth to the chest. Okay? Even that can cause myocardial contusion. And remember, he may not have the broken ribs to go along with it because, well, at 14 he's probably a little less pliable, but okay? Or due to a steering wheel impact. How often do you think we see this? How does the use of airbags or the deployment of airbags affect this? Seat belts. Yeah, it depends. I mean, who in here doesn't have a car that has airbags nowadays? Secondary impacts, though, remember, we hit something the first time and then somebody else comes along and hits us. We don't have any protection from that secondary impact. Remember that from the other day? Okay, this is going to act like an MI. Okay, you guys remember MI, right? We haven't mind dumped all this, right? What's MI stand for? Very good. Okay, so it may produce arrhythmias. So how are you going to know that?
They have a pulse.
Well,
Isn't arrhythmia like a fluttering?
Arrhythmias are a lot of different things. So basically, if I'm checking your pulse and it's irregular, you have probably some sort of arrhythmia. Okay? It could be PVCs. It could be, anything, because there's several different types of arrhythmias. Okay? So you guys will maybe know if you assess a pulse and you go, oh, this is irregular, hold on a minute. They may have myocardial contusion. Okay? And it may cause cardiogenic shock and hypotension. Again, anything that you're going to do that's going to affect your cardiac output. Remember we talked about cardiac output. Okay? Signs and symptoms, cardiac arrhythmias after blunt chest trauma. Angina-like pain that's unresponsive to nitroglycerin. Okay? And then chest pain independent of respiratory movement. So what does that mean? It means it doesn't matter if I breathe in or out. It's not going to make it any better or worse. Isn't that sounding an awful lot like angina? Because generally, angina doesn't get worse with movement, does it? I mean, it gets worse with activity. If I get up and I'm running around, of course, I increase my oxygen demand. But just breathing, that movement isn't going to affect it.
So
Okay?
what about, another difference would be like the age of someone?
No, because anybody can have myocardial contusion. So myocardial contusion, again, this is my mechanism of injury. This is my my high index of suspicion based on the injury and how my patient's presenting. So if I was involved in an accident, right, and my airbag deployed at first and I was okay, mostly, okay, and somebody else came along and rear-ended me from the back, I have no protection for that. By now I've probably already taken my seatbelt off, whatever. Okay? And now I hit my steering wheel and I have chest pain that sounds like I'm having a heart attack. No, it doesn't hurt anymore when I breathe or move. No, my chest is just hurting. It's this dull pain. So if they sound like they're having a heart attack, but the presentation and the mechanism causes me to have that high index of suspicion for this. Okay? This isn't somebody who maybe has cardiac history. You or I could have a cardiac contusion.
So it's the incident that happened?
Yes.
Okay.
It's that high index of suspicion based on what is the car. Remember, we talked about this. What does the car look like? What does my scene look like?
We can't do anything about that, can we?
No, supportive care. There's a lot of things you're going to find. We do a lot of things. I'll tell you, you know, what's the biggest thing we do for any trauma, guys? High index of suspicion, early recognition, and rapid transport with supportive care is really what's going to save these people. Okay? High O2, spinal immobilization if necessary, transport and consider ALS intercept. Okay? Cardiac tamponade. Remember, we talked that this is one of those absolute life-threatening events. This is one of those things that we're going to look for first, right? You guys remember that? So when you think about this cardiac tamponade, think about a hemothorax. Because the way you can kind of think of it is every organ has its own little sac. Okay? So just like you have the pleural space, the pleural lining of the lungs, you have a little sac around your heart as well. It is essentially the same thing. You bleed into the sac, it puts pressure on the heart. Everybody following so far? Okay? So the heart gets compressed. Again, blood's not able to enter the heart as well, and then cardiac output fails. So if you look over here, you see this little lining here. Here's the pericardium, and that's the sac around your heart. Okay? So this is when you have damage to the heart, and then you start getting blood accumulation in here, and it just bleeds into your heart, or to that space. So again, it puts pressure on the heart. It can't go anywhere. Right? So the more pressure I put on the heart, the less blood can come into the heart for me to pump out, and the less of a squeeze I get. Right? Remember that rubber band? If I'm going to flip Devin with a rubber band, you know what? Matter of fact, because I'm good like that. Okay. So let's talk about the squeeze of my rubber band. If I can only move it this far, what are the chances I'm going to hit him? Not very. So when I restrict the amount of squeeze I can get, that's going to affect how far I can shoot my rubber band. The heart is the same concept. See how that works? So when you start compressing it and you start having to kind of shoot your rubber band in a much smaller spot, you don't get the push or the kick when you let go. Right? So that's kind of what pericardial tamponade does. Okay?
How would you decompress that?
We don't, but the hospital takes a big needle on a big syringe and they feel for your xiphoid process and they stick it up and they puncture that sac and they drain it off and then they get your tail to the OR so they can fix the damage to the heart that's causing it. Bad stuff, right? Okay. Signs and symptoms. This is Beck's triad. Okay. Signs and symptoms are hypotension, unresponsive to treatment. Well, what does that mean?
Like, when you give them nitro or something like that. 'Cause that's not
Well,
gonna help them,
right, we don't want to give them nitro. We don't want to give these guys nitro.
you know, but how would you know?
Well, this is usually if, and this is something you guys may need to know, suppose you have an ALS partner and your ALS partner is giving them fluids. Right? I'm giving you fluid because you have a low blood pressure. Ideally, when I give you fluid for a low blood pressure, I should increase your blood pressure a little bit. Okay? But I don't because I can't squeeze to get the blood out, to get the fluid out. Yep, they have hypotension, not because of loss of blood necessarily, but because my heart can't squeeze to push it out. Do you see the difference? That's why it doesn't respond to treatments. You okay, Nellie? Okay.
Can this only happen to trauma or by trauma?
Generally, yeah. Because it takes significant impact on the heart, right? Because you have to have structural damage to the heart. Okay? Increased central venous pressure, so distended neck and arm veins in the presence of a decreased arterial blood pressure. All right? And then if you listen, their heart sounds quiet. So when you listen to the apical pulse, which is the pulse at the heart, it's really hard to hear. It's very muffled. Sounds far away because you're listening through that sac of fluid instead of the heart itself. Okay? Narrowing pulse pressures. So what does that mean? Let's talk about our blood pressure for a minute. You remember, my systolic pressure is what? Right. The amount of pressure exerted against the walls of the artery when the heart contracts. So what is the diastolic pressure? When it relaxes. So what happens if I can't get that squeeze? They get closer and closer together. Right? Because it doesn't affect my at-rest pressure. Right? Because it's at rest. So the at-rest pressure won't necessarily fall, but my systolic pressure will get closer to that diastolic pressure because in the end, it's all under the same pressure because of the squeeze on the bag. Is everybody understanding that? Okay. And then pulsus paradoxus. That's basically when, you remember that 80, 70, 60 rule? Okay. That is when I have pulses that go away when I take a big breath in. Why? What happens to my pressure inside my chest when I take a big breath in? Yeah, it increases. So I've already got pressure put on my heart. Now I take a big breath in and I increase that pressure even more so it can't kick that out. See what I'm saying? Because that comes directly off the artery and it comes down the subclavians, remember? No? A little bit? Paige, are you with me? Okay. All right, so what are we going to do to fix them? Secure the airway, high concentration of O2, rapid transport. Definitive treatment is pericardial centesis. John, that's that big needle that we're going to stick in your heart. And, do you remember the other part, Jacob? What's the other part of definitive care? So what else does this people need indefinitely? I mean,
Surgery?
yes, absolutely. They need to go to surgery because there's a hole somewhere in the heart from the damage. They have to close that or else it's going to continue to be a problem, right? It's just going to continue to leak into that pericardial sac. Make sense? Traumatic aortic aneurysm, basically caused by sudden deceleration, massive blunt forces. Okay? Vehicle collisions, fall from heights, crushing chest trauma, blunt chest trauma, animal kicks, about anything. So you can have this almost paired up with anything else that we've talked about, right? Because all of this falls under what can cause things like rib fractures and pneumothorax and that kind of stuff, okay? Rupture usually occurs just beyond that subclavian artery. So remember, we talked about that. If I have this structure, okay, remember my aortic arch, I'm not a very good drawer, kind of comes up like this, okay? And at the top of it, it's got these three, you guys remember that? So these are anchored, aren't they? They're anchored as they travel and attach. This isn't so much, because what is this? Where does this go? Kind of just comes down literally all the way down my midline until it splits right before it goes into my femoral arteries. Right? I mean, it kind of bifurcates here and there because we've got to supply blood in the middle. So essentially, this isn't anchored. This is not an anchored structure right here. So what happens when this is anchored and this isn't, and I have that sudden deceleration? It just tears. Okay? Everybody kind of understand how that works?
And you're where the other three are.
It tears usually right after that.
I mean, that pretty much kills you, doesn't it?
Yeah.
I mean, there's no,
Yeah.
unless you're there unless it happens at the hospital or something.
You could probably have this rupture going on your way to the OR. And, yeah. Okay? Signs and symptoms. Increased blood pressure in the arms in the absence of a head injury. Okay? So this, remember, well, we haven't talked much about that yet. We'll get there. Decreased femoral pulses with full arm pulses. Boy, wouldn't you think that would be different? Right? Why is that? You're looking puzzled, Shaver, so let's talk through this.
No, if it's torn off, how's there any pressure at all?
Well, it may not be a complete tear. So it could be a hole that's
So wouldn't
leaking.
that be decreased pressure then?
Yeah.
It says increased BP in your arms.
No. It's after the 3. So these 3 at the top, remember that I drew over here? That's what feeds your arms. So they are not affected.
I get that, but still, like if there's a hole where like your main artery out of your heart is like it's coming out, how is there still pressure to push it even through your arms even though it's...
Because it's after where it delivers
I
at the
know,
heart.
But still.
Because the pressure only moves one direction.
Okay.
How big is your aorta?
Honestly, I don't know. I know it's the biggest vessel you have. I mean, it's probably relative to the size of you, right? Because it's got to come off your heart and it's got to feed your body. So I would guess Matt here, his aorta is probably going to be bigger than Jessica's.
I'm picturing like a water hose for some reason.
Yes. That's kind of what I would picture. And again, like I said, his is going to be bigger, right? Because he's a bigger guy. He's got bigger structures. His heart's going to be bigger than hers. That kind of thing.
Would it actually increase the BP or just leave it the same? Why would it be increased?
Because it's providing more pressure to try to get blood to where it's got to go, right? Remember, we start doing compensatory things. So what do?
Well, you can say you pump more or whatever.
Yeah, there you go. We start trying to tighten up, and it's very short, and it depends on the size of the hole, right? So it may not be a complete shear. Okay, it may just be a little tear in the lining where it's building up in between kind of the walls of the artery. You with me? Okay. So which is why I won't have the pulses as strong in my femoral as I will in my arm, right? Because it's pushing real hard to get here, and that's before the injury. So after the injury, I'm losing pressure because I've got a leak in my pipe, right? So if I have my garden hose, put my garden hose, and now I put a hole, even if it's a pinhole pressure, I've got higher pressure before the hole than after the hole. Okay? Does that make sense? No? And then detection requires, again, a high index of suspicion. Respiratory distress, and then ache in the chest, shoulders, lower back, sometimes in the abdomen. It's going to depend. Okay? Management. High concentration of O2, assist ventilations, suspect spinal injury, and then rapid transport. Okay? Associated abdominal trauma. During expiration, the diaphragm is high, right? About the 5th rib, which is significantly high. Okay? So trauma to the chest below the 4th rib equals an abdominal injury until proven otherwise. Okay? So basically, remember we kind of talked about that. Anything between my belly button and here is considered both chest and or abdomen. All right? We need a break?